we've got two interesting and very topical subjects to get us started in thinking. So first of all, Nick Payne is going to talk about the latest evidence with the vaccination programme and its impact on the pandemic. And Ian Bowns is going to start us thinking about the government roadmap and the implications for easing out of lockdown. And there'll be lots of time and opportunity for questions and answers, both to the speakers and also within the breakout groups. And we aim to finish at least by 5:30. So without further ado, I'll hand over to Nick. Let Nick introduce himself.
Thanks, Fran. Hello, everybody. My name's Nick Payne. I'm a retired public health doctor, director of public health in North Derbyshire, and not quite retired, professor of public health at the University of Sheffield. I'm just going to share my screen, which should come up. Right, okay. So for those of you that have been before, I know lots of people have, this is now part of a series because it goes back since the beginning of the year, really, a fortnightly series of vaccination updates since the vaccination really sort of started rolling out. So it doesn't aim to cover everything, but it aims to pick up what are essentially my top 4 points of interest in the last couple of weeks. So these are the 4 topics I'm going to talk about. A little bit about immunity to COVID. We know a little bit more about that than we did even a fortnight ago, and I've got a few things to say about that. We've got quite a lot more information about the effectiveness of vaccines from real as opposed to clinical trials. Clinical trials are real, but the real rollout studies, which obviously involve huge numbers of people. Some information about variations and inequalities in vaccine uptake, and something about vaccine uptake data in Sheffield. So this slide is a bit complicated, and I apologise, and I'll take you through it slowly, I hope. It's about the sorts of immunity that we need to think about when we're talking about immunity to COVID. And it splits immunity up into immunity or resistance to transmission, passing the disease on, and resistance to the disease itself, the host disease, which it really means getting ill, getting very ill, or dying from the disease. It's so that, see the difference. One is how resistant you are to getting enough to pass it on, or to pass it on to people, and the other is how resistant you are to becoming poorly or seriously poorly or dying. The first one is on the left, the virus transmission one. And the main thing that helps to stop the virus being transmitted is neutralizing antibodies, which are in the little funny diagram in the sort of middle of the left there, are little Y antibody molecules, red Y antibody molecules attaching themselves to the virus, which is the sort of reddy blue blob in the middle with spikes on. And dealing with that first of all, this is perhaps more mediated by antibodies from B cells, which are sort of white blood cells. And it's the sort of thing that the virus will tend to evolve to become resistant to, because obviously if you've got 2 different viral populations going on at the same time, the one that spreads itself more is going to be the one that's successful. So that's the one that is likely to change. The second sort of resistance is resistance to getting seriously ill once you are infected. And this is mediated by a slightly different part of the immune system, particularly a different sort of white blood cell called CD8 T cells, which are the ones cytotoxic, cell-killing T cells, which kill the cells that have been infected with coronavirus. And here, the virus won't tend particularly to evolve to become more lethal, not least because if a virus is very, very lethal and kills everybody more or less straight away, it can't spread. And the viruses that spread widely in the population are the ones that are infective, but don't tend to kill people. So the host will tend to evolve to become, the host and the virus will tend to evolve a bit together. And if it is true that the virus really did arise from bats, then you think of all the bats that live in caves together, the chances of them spreading to each other is very, very high. But they've evolved in such a way, the bats have evolved and the viruses have evolved with them, so that doesn't happen. And just finally about that, 2 different sorts of vaccines were introduced for polio. The first one, introduced in the late 1950s, was the one that stopped you getting the polio paralysis particularly, but didn't prevent transmission. And the slightly later polio vaccine that you took on a sugar lump, the oral vaccine, did a bit of both, but it was particularly good also at stopping spreading of infection. So just to differentiate that there are 2 different sorts of immunity that we need to consider when we're talking about the effect of immunity on the coronavirus. So, okay, so while we're talking about developing immunity, it's worth thinking about how the population is getting on in terms of developing immunity just from being infected itself, not from being vaccinated. And this is a graph with the times along the bottom. Look, it starts at left with June last year and goes right through to end of January or mid-January this year. And it shows the proportion of the population going up to 15% at the top there, who have got positive tests for antibodies, which almost certainly means that they have at least some, and probably some quite good immunity for the infection. And indeed, if you have been infected, as I think I mentioned last time, that acts to reduce your risk of reinfection by at least 83% for at least 3 months, for at least 5 months, probably longer, 6 or even longer months than that. We don't quite know. So that even without vaccinating anyone, a proportion of the population is becoming, at least for a while, immune to the disease, which is good. And that increases to about 1 in 5 in London, looking at that figure by different parts of the country. Right on the left is London, but not far from the left is Yorkshire and Humber, where nearly 1 in 5 seem to have developed some immunity, just simply because they've been at risk and they've got the disease and they've now got antibodies. So that sort of, if you like, acts on top of the vaccination program, but of course it's at the expense of people becoming poorly and some people dying. So that's all I want to say about developing immunity. I want to go on to looking at the effectiveness of the vaccines. And I did this slide about 3 or 4 days ago based on the Scottish hospital admission study, which hit the press before the weekend. But since then, there have been at least 3 or 4 very, very similar studies. One that's just come out yesterday from England, several from Israel, where they've done lots of vaccinations. And all of them show the same sort of thing, which is very good because they're all from different parts of the world. They're all saying that even after only 1 dose of vaccine, either Pfizer or AstraZeneca, this is the Scottish data, that the reduction in hospital admissions in those people that had 1 dose compared with what you'd expect was about 85%. So the vaccine efficacy was about 85%. And it was sort of looked in the press as if AstraZeneca had really beaten Pfizer to it on this one. Well, I don't think that's actually borne out by the real data. If you look at those little black lines in the middle, it shows how confident we are of those exact results. And I think you can say that they're both effective, but you couldn't say that there's any significant difference between the two. They're both pretty effective. AstraZeneca's just beaten it to the post, but that could well be because of chance, because they haven't studied enough people yet. And that's borne out by other stuff. So, okay, moving on from there to looking at variations and inequalities. And the thing that has, this is based on some information from a big study of health service data in England called Open Safely, with about 23 million people's GP records looked at anonymously. And this is the slide, if you like, that was published but gets less coverage. But it's very, very important that more deprived parts of the population, both in the 80-plus-year-old and the 70 to 79-year-old group, who were the only data they had up until till around the beginning of February. But in both groups, there's at least a 10%, or there's around a 10% difference between uptake in the most deprived compared with the least deprived areas. And this is something that I think we ought to be taken very, very seriously and thinking about how we deal with. What does get more attention is this slide, which is the variations by ethnicity. And it's not the same for all ethnic groups, as you can see. It's reflecting a similar pattern across the two ages, but it is looking at quite relatively old people so far. And whether that's going to be borne out when we look at younger people, we don't know yet. And the other thing that seems to be happening, and this is very important, is that this difference between the different ethnic groups is not stable. It's probably not staying like this. And the gap is actually narrowing, which is due to, in no small part, to a lot of effort by ethnic minority population, people of various backgrounds, both medical backgrounds and religious backgrounds and so on, explaining more information about the vaccine than has been, and better information obviously than is out there on social media. So, okay, so that's what I wanted to say about variations in inequalities that have come up from that big study. I wanted to just look at some variations and inequalities more locally. Now, if we lived in Birmingham, we'd have really good data on the variation in vaccine uptake. So there's a map on the left of Birmingham divided into lots of small areas, not quite electoral wards, they're a bit smaller than that. And you can see that in the fairly affluent Sutton Coldfield area at the top in the sort of purpley blue colour, 95% of the over 80s have been vaccinated. Whereas in this little area of Alum Rock in the middle of Birmingham, only 60% have. So there's big differences, and the whole map of Birmingham can be coloured in like that. We've just shown that to show how good the data from Birmingham is, and how good that they can look at the infection rate in those areas and the ethnic population and so on. The very best that I could find for Sheffield is that it's not very good, and I apologise, it isn't very good map on the right, but you can broadly recognise where Sheffield is. You can see where going from the top, Walkley and Crooks, going down to Worlow, Millhouses, Manor, and so on as you go around. If I zoomed in any more, if I zoomed in any less to get even more of Sheffield, because we haven't quite got it all there, all the places would have disappeared. But what you can see is the all too familiar, unfortunately, pattern of the more more affluent south and southwest areas of Sheffield having the lighter colours, which is showing not vaccination rates here, it's showing case infection rates, the number of new cases. And the white doesn't, when it says suppressed, it means that the numbers are so low that a reliable rate isn't given, but it is nonetheless very low. So the whiter or the lighter green or the greener colour, the lower the infection rates, and the bluer and the darker bluer, the higher the infection rates. And it does broadly bear out the same sort of pattern with lots of other diseases and with deprivation in Sheffield. So what I really wish we had is some data about variations and inequalities in Sheffield, but we haven't got any. And I think one of the things we're going to try hard to do is to try and get some of that information, but we could do with some support and help in order to pressure the powers that be to allow us to look at that and work out what we do about differences and inequalities. And that's the end.
Thank you very much, Nick. I think that's really, really thought-provoking. I think what we should do is, has anybody got any questions for Nick now, before we move on to talk about the roadmap? So I can't see. No. I've got one question, Nick. On the effectiveness of the vaccine, how long does it take for antibodies to, for the effect to produce itself after somebody's been vaccinated? At one time, I mean, did they sort of look at that when they did the effectiveness of the two vaccines?
Nick, you're muted again.
Okay, sorry. I didn't do it myself. Someone must have done it. The Public Health England study that was published yesterday, I think it was, the preprint that's available, and I had a look at that today, and they looked at the data at sort of like pre-vaccination in the first week, in the first couple of weeks, and then after 4 weeks. They didn't, I think, go in longer than that. And their endpoint was at the 4-week endpoint, but it clearly shows that the longer you go in that short period, the more efficacious the thing is. But we don't know yet. I mean, once you get to, like, you saw the confidence intervals on there. I mean, they were getting near to 100%. So once you get up to that sort of level, it'll be hard to detect a difference from like 85% going to 95%. So I suspect that it's 4 weeks is getting pretty much nearly all the way there.
The antibodies start to rise.
Well, no, let's be quite clear. Whatever the antibodies are doing, it doesn't really matter in a sense. The reduction in admission rates is detectable after 4 weeks. Okay? It might be the CD4 helper cells. It might be the CD8 T cells, natural killer cells, all that sort of stuff. But it doesn't really matter. The real outcome that matters, but the people who are poor enough to get into the hospital shows that as an outcome.
Okay, well, thank you for that. Right. Okay, are we happy to move over onto Ian to talk about the roadmap? So Ian, if you can introduce yourself.
I will. Hi, my monitor's just warned me it was about to switch off, so obviously wasn't moving the mouse enough. Good afternoon, everybody. My name's Ian Bowns. I don't think I've spoken to one of these sessions before, but I'm yet another one of the relatively recently retired public health doctors who are involved with SCCT. And I'm going to now share my screen and just work my way through a handful of slides. Now, I think you'll all be fairly familiar with these dates, and I'm not going to read these out because you guys can all read more quickly than I can read them out. But essentially, I mean, it's supposed to be a 4-step plan. There actually appear to be 5 dates. Working away at least reasonably sensibly from relaxing restrictions on people making social contact in the open air, and then gradually reducing the restrictions on contact within retail businesses and larger enclosed spaces. And then finally, the intention is to remove all the legal restrictions on social contact in June. Now, as I say, you can see the detail there. In some respects, you could say the big thing that doesn't fit the pattern is the early opening of schools, but actually quite a lot of children of key workers and similar have already been in school. So there are a number of children who are already been in contact pretty much throughout the winter. So there is already been a partial and it's kind of incompleteness to that restriction. Now, the government have described what they call 4 tests, that the vaccination programme continues successfully, and it seems to be moving very quickly. There appears to be a little bit of a lull at the moment because I think at least one of the manufacturers are increasing their production facilities, and in order to do that, they're having to, in effect, close some of that down to do so. Evidence shows that vaccines are sufficiently effective in reducing hospitalizations, and Nick's already touched on that. Sorry, you distracted me. My wife has come to listen to me. I have a
Oh no!
No pressure. No pressure.
No pressure, Carol.
Oh, yeah.
Anyway, and Nick's already outlined the evidence that we're starting to see that the vaccines are effective at reducing hospitalizations, and some of the data, certainly from earlier data from Israel and some of the UK data now, is starting to show that mortality seems to be falling more quickly among the older age groups who got the vaccine first, and it fits with the time of when you might just expect to start to see the earliest impact on something like mortality, which people do not get infected and die immediately. When they do get very ill, it takes a certain amount of time from the infection to do that. So it takes time for that evidence to emerge. That infection rates don't risk a surge in hospitalizations that would put pressure on the NHS. I think it's worth bearing in mind that poorly controlling COVID, allowing it to put pressure on the NHS, means that we will actually have a much wider health impact, adverse impact on the population, because people who need those hospital services and won't be able to get them because they'll be fully occupied with COVID. And so we really do need to give the NHS the slack to start to catch up with some of the certainly planned treatment and try and make sure that we can pick up any serious illnesses that have been missed over the last year or so. And the final point that the government talk about is the risk of new variants. And we've seen yet another one manifest itself in the UK with these handful of cases of what I believe to be the Manaus variant from the Amazon region in Brazil. But at the moment, we're in a fortunate position that we think the vaccines seem to provide reasonable protection against all those variants when you actually look, as Nick said, at the data. Now, the government did, in effect, kind of say, well, where are some of the issues? And they talked about schools, they talked about test, trace and isolate, they talked about support for isolation, and they talked about border controls. But they didn't actually say very much new about what they were going to change with these things. I think it was probably a recognition in their minds that everybody is apprehensive about some of these areas, because when we look at them, they do appear to be potential areas of risk. So I'm going to move quickly on to what I think might be some of the risks of this overall approach. Now, as I've said, despite mentioning these areas of concern, there's very little new action. There is a feeling, it'd be easy to feel, that all the eggs are in the vaccination basket, because the current test and trace service has been demonstrated to be not really up to the job. There are issues with people coming forward. There are issues with people self-isolating early enough. There are issues with the tracing, which have been illustrated partly by the handling of this, one of these cases identified with the Brazilian variant can't be tracked down, which surely shows that there must be some weaknesses in this system. I think and there is another risk in that even within the what they're saying, and certainly what they've written, there is some mixed messaging. For example, there is the stay-at-home rule ends, but the encouragement continues. So they're saying, you know, you don't have to stay at home after a certain point, but please do while you can. And I think while most people appreciate that, the way different people will interpret that is going to inevitably vary quite a lot. The plan more or less accepts that cases, and with cases, some serious consequences. We know that a proportion of people who get illness will have symptoms which persist, and they may be quite serious. And we know that however well protected those at most risk are, there will still be a few people who will lose their lives from infection with COVID. So the plan more or less accepts that with the easing of restrictions, there probably will come more cases, with more children back at school, more people back at work, more retail and hospitality open. There is inevitably that risk. In fact, the quote, we must all remember that COVID-19 remains a part of our lives. So just to reiterate, while the restrictions and the vaccinations will put downward pressure on cases, the reopening and some of the weaknesses in the other systems may well push cases up as contact increases. One thing I think that there is an issue is that there are no actual criteria set out. While they've talked about the measures that they're going to look at, they haven't said, well, if such and such a thing happens, if cases go above this, or if admissions go above this, or if they stay above any level. So it gives them an awful lot of wriggle room to just persist, even if there are emerging problems from this strategy. And I think there's one particular group, I think if you look through the information that we've already got on who takes up vaccine, who is at risk, who may pose a particular risk. And I think that's going to be some of the vulnerable people who are unvaccinated in multi-generational households. And I was thinking, you know, we know that certain communities have got higher proportion of multi-generational households, but there are quite a number still within the community. And I may be showing my age, but when I was brought up, I was actually brought up in a multi-generational household. My grandmother actually lived with us throughout the entirety of my childhood. And had we been in this position now, I could well have taken the virus back from school into a household with a vulnerable person who was getting into her 80s. Now, I think those are the things that I would see as being potential risks with this. I would like to finish by saying I do think the broad direction's right. I think the speed may be an issue, and I think it is, you know, the effectiveness of the vaccine is allowing us to do this, and it's something that's to be profoundly welcomed all round because of the harm of these restrictions. So with that, I will finish and take any questions.
Right.
But in the meantime, I will move on to the questions that we'll use when we go into breakouts so that people can have a look at those while we chat.
Right. Well, my watch says we've got about 5 to 10 minutes before we go into breakout rooms. Alex, is it possible to get up on the screen everybody's face or thing? Because I've only got 6 people, so I
And
can't.
if I stop sharing,
Yeah, that's
stop
fab.
sharing
Yeah,
for a bit, and if I make sure that I'm not,
thank
yeah,
you.
I've taken the spotlight off me. So if you go to gallery view, Fran, you should see everybody.
Yeah, I've got it now. Yeah, I can see everybody. Yeah.
But
Okay.
Fran, there's a question in the chat from Faraz, basically asking of Ian about the roadmap, and is it following the science or is it still economics and politics?
Both. I mean, I think for us, inevitably, it's going to follow both. I think broadly speaking, you know, there is science behind much of this, but not all the science is just purely science about COVID. It's also about, well, what are the social and psychological risks to children from being outside their education for a while? You have to take account of the broader situation as well. But I think the government are consummate politicians, and they're quite, I still think, desperate and potentially a little bit not sensitive enough sometimes to the risks. They're really keen to open things up. They're under a lot of political pressure to do so. That's my view. That's my view. Others will have a different.
Does anybody want to comment on that at all? No, can't see it. I mean, it's very balanced, isn't it? What they need to do. Faraz, do you want to say something, Faraz? Hiya, hiya, Faraz. Do you want to?
Yeah.
Can hear you now.
Yes. Do you know what? It just still really looks a mess because I mean, it just seems that they have tried to do this pandemic and austerity both at once, and they're making an omni shambles of it. Yeah. And now what if they really wanted to, you know, they have borrowed £400 billion from the IMF.
Yep. Yeah. I mean, it's costing a lot, isn't it? This pandemic. Yeah. Okay.
And what they could have done really is I don't know, they collected 22 billion from austerity.
Yeah.
So I mean, what was it? Wouldn't 22 billion be enough to just reverse the austerity and start supporting everybody properly, instead of racking up national debt for the future and causing economic collapse?
I mean, I think it's true that a lot of things could have been done a lot earlier. You know, this country has got the worst death rate, I think, in the world, and there's the economic issues as well.
And they keep doing it. This is ongoing. They're not changing their. I just don't know how we are letting them do this.
Well, I wouldn't normally be a big defender, and I certainly would be very personally. I'd be very critical of how they manage things early and in the middle of this. We are in a better position because of vaccination.
Okay,
and my perception, and I would think others would probably see it similarly, is that there is less scope for the poor management of test and trace and the poor management of isolation to do harm, because we've got more vulnerable people vaccinated and protected. And we've got case numbers coming down, which hopefully will lead to as well to fewer infections. So we are in a better position. We're in a much better position. I just think there are risks if they do not manage to keep the vaccination program going. And at least maintain the other control, some of the other controls they've got in isolation, helping people to isolate, and in test and trace, because both of those are imperfect. Sorry,
I've got someone else with
Carol's.
a hand. I've got someone else with a hand up. Carol, would you like to?
Hiya. I'm just wondering if anybody can answer how does the vaccine rollout to younger people coincide with the opening up of lockdown and things, and are they doing herd immunity by the back door,
Right.
with young people?
Does anybody want to answer that? Nick, would you be able to answer that?
I'm not quite sure what you mean. Can you explain what you mean by herd immunity by the back door?
Carol, what do you know what you mean by herd immunity by the back door?
Well, I mean, it seems that why don't before we open up and roll out opening shops and everything, that why don't we make sure we've vaccinated everybody that wants a vaccination just before we do that? You know, just a few more. I mean, we've been at this for a year now. Would a few more weeks, months make that much difference?
I understand exactly what you mean now. Okay, thank you. Well, that's a really, really good question, and where you start to open things up in relation to how much protection the population has is enormously difficult, because the whole lockdown is immensely damaging to people's health. It's saving lives because people aren't dying of COVID, but there's vast numbers of just NHS treatments that are being postponed or even abandoned because we've locked down, not to mention all the effects of lockdown on mental health and well-being, particularly, and the group that are perhaps hardest hit by that are just the ones that, in other words, younger people and kids, who have least to fear from COVID because it is less likely to kill them or even cause them to be seriously ill. So at some point you've got to say, look, the balance is that it's better to get kids back in school and to release all the horrible effects on mental health and so on that are really devastating communities and particularly young people, in order to get the balance of that right.
Yeah, thank you, Nick. Yeah, does anybody want to add to that?
No, I think that's well put. And I think that striking the balance between releasing restrictions steadily over a period, while you ensure that the last groups that are at very much increased risk of serious complications and dying of COVID is what they're trying to do. And broadly, it looks as if we're there, we're in the right place to be starting to do that. My concerns are if they're not genuinely sensitive to things that start to go wrong, we may get some of those harms back. So I think we will be able to keep progressing. It's just whether or not their pace is going to prove to be too quick, and whether they might prove too insensitive to slow down, because he's basically said he wants to make this irreversible. We know what he's done in the past in making things irreversible. He sent the kids back to school on a Monday and then kept them at home on the Tuesday. And it's that sort of thing we want to avoid by having them being more sensitive and being planning better. as we go along.
I think we've got more things in favour of this working, because they have finally realised they need a phased approach and to test each step. We've got the vaccination programme, and we're going into spring and summer, and we know from other parts of the world down the south, that southern hemisphere, that the pandemic does wane in the summer months.
Yeah.
So I do think, you know, this stepwise testing, you know, does stand, and to be honest, you know, we do need to get, you know, I'm glad that it's the children that are going back to school first, rather than opening up other, you know, aspects of the economy, because it is a big step. Okay,
Steve's got a finger up.
Steve.
Yeah, it's just that Sue's posted a question
Right.
with regard to is step 4 too big a leap to take, of opening up to every event, you know, everything open in one go? So just looking for views there, really, I think.
Yeah. Any views on that?
I'm in a very unusual position in relation to that question.
Yep.
I missed it. I'm actually for my sins entries coordinator for Buxton Festival Fringe, which, in case you don't know, runs for the first 3 weeks of July. So the timing could in parallel with Buxton International Festival, and it could be that it could be very fortuitous for us, or it could be a very huge risk. What my observation from that about large scale events is that I strongly suspect that people who are putting these things on are going to be very cautious about how they undertake that. They're going to be very sensitive, because apart from anything else, they know that the public are apprehensive. And although everybody's keen to get back to normal, people are also still concerned that things could go wrong. So I think that a lot of voluntary precautions will remain in place. And I think that, and I've been consistently impressed by how much the people who are organising things like this understand now about the transmission of COVID and how to avoid it. So it is a risk, but I don't think we're suddenly going to go back to things exactly as they would have been in the summer of 2019.
Yeah. Okay, if there's no more questions, then I think, can we go into our breakout rooms and perhaps continue the conversation in a smaller group where people can have a proper chin wag. So Ian, is it possible to put the questions up again? You don't have to talk about these. This is just a pointer, which is feelings and concerns about easing restrictions. Is one topic, and the other is ideas to reduce inequalities in COVID vaccination uptake, because we'd welcome any ideas for that as well. So we'll go in the breakout rooms for until 5:10, and then come back, and then very briefly feedback, and take it from there. Okay, so if you press the thing for your breakout room now. So if we very quickly go through all the groups, so who wants to start?
I could start for the group I was in, which I think was group 4. And we can't say we stuck to our homework entirely, but we did have really useful discussion. If I want to tackle the question we did look at to some extent, was how do we feel about the easing? I think the general feeling was cautiously optimistic. Phrases that other people used were light at the end of the tunnel, and more positive this time. although there was still a degree of apprehension about whether or not it would be handled as well as it might, and whether everybody's learnt their lesson from previous waves. I think the vaccine is allowing us to be more optimistic. There was quite a bit of concern, though, about what was seen still as mixed messages of, you know, we want all the restrictions gone by June, but you've still got to be careful.
Yeah.
You know, make your mind up.
Yeah.
Kind of thing was a little bit of it.
Yeah.
We spent a lot of time talking about the fact that support for people who need to isolate has not been good enough, and there is no reason to believe that anything that's been said will mean it's going to improve, although it really should improve. And that we talked a lot about trying to provide something that was, you know, sensitive to the needs of individuals and families, and actually made doing the right thing the easiest thing to do, instead of at the moment where they're making it the hardest thing to do. We touched on vaccination, and I think I'm afraid the only point I made of any use within the group was I think we should make more of the message that although there are inequalities in uptaking the vaccine, the majority of every group is accepting the vaccine, and I think that message is persuasive to some people in all communities. I think we should just make a bit more of saying most people are taking this up. Don't get the wrong idea, everybody. The vaccine is popular in every group.
Yep. Okay. Thank you for that.
So I'll shut up now.
Did you have a group
want to add anything I missed? No.
No, Ian joined our group, so he's given the report back. Unless Riel and Carol want to say anything.
Yeah.
Right.
Carol's muted. She's speaking but muted.
No, actually, Ian has reported us in line with our discussion, and thank you, Ian. You did this very well.
That's right.
Thanks, Riel.
Cheers.
Who else had a group? I can report back from our group. We had a very interesting, wide-ranging discussion. We had Rebecca, who was who's leading on the Magpie project for Mind, which is about hoarding, and so we learnt a lot about the impact of the pandemic on people who hoard, and how that has been dealt with. I mean, what we came out of this was how fearful people are going to be, and what people need to do in, you know, because the guidance is actually for coming out is quite complicated. You know, we've got these stepways, but, you know, trying to interpret what it means for you in your own particular circumstance. We also had Sue on our group who runs a lunch club in Nether Green, and people desperate to come back to that because they've been isolated and everything else. But it's how can you do that safely? And there's all the details in that about how, you know, transport for people to get there. She's done a sterling job keeping all the volunteers who do the cooking and everything else on board. But it's what are the steps, you know, towards doing this? So it is, you know, the message I was getting through is how do we interpret this guidance, and also, you know, how are we going to get back to some kind of normal? I mean, Rebecca she said, what I want to see is people back on the streets and smiling and everything else, and we just need to. But people are fearful, and how do we deal with that? We also had a quick talk about what topics for future webinars, and long COVID was very much which we are doing in 2 weeks, was you know, but also the links with chronic fatigue syndrome. This thing about getting back to, you know, how do we cope with all the steps was talked about as well. So that's what I took back from our quite wide-ranging discussion. So I don't know if anybody else wants to say anything. Sue, Rebecca, Maya. Okay, right. Anybody else want to feedback?
Yeah, I'll feedback from our group. We had Karen, who's unfortunately left us, who worked for Sheffield Reach, South Sheffield Reach, and so a community support organisation, actually dealing with the community who are largely in the same PCN hub where I'm volunteering on vaccinations as a vaccination volunteer. And so she's seeing people in the community who I've seen down at the vaccination hub, and similar stories about how these people have been, well, she used the term rushing down to get their vaccination, the people in the over 80s age group, you know, and my view of the rushing down is when they arrive, just seeing those people struggle across the car park to get into the centre is just a revelation. Actually, they're real pioneers in my eyes. And then Sue, another Sue was in our group who came as a Sheffield resident but worked for the Arts Council. So what Karen and Sue shared is this quandary of how to open up venues again for activities, and really no answers yet, because there are no answers, but just having to deal with all of what that means, you know, how to socially distance and arrange venues and get back to normal life. Karen had one interesting, she said they get questions about vaccinations, you know, lots of questions on the vaccine. She quoted side effects being a big question, and then another anecdote about an 85-year-old lady who'd had her first vaccine but wanted to give up her second dose so someone younger could have it.
Oh.
Which I thought was a fantastic story. So the view was, no, tell her to get a vaccine, tell her to get a second dose, she needs it. But yeah, I'm wondering, Nick was in with us as well. I'm just wondering if I've missed anything else, Nick.
Nick, somebody's muted you, Nick, I think.
Yeah, we had a bit of a conversation about sort of location of vaccination centres, and what it was largely around sort of a little bit about sort of big centres like the Arena versus local primary care, and also about community type venues versus NHS type venues. And we sort of knocked around a bit about issues about, well, okay, there are some communities that for whom a certain sort of venue might be great for them, that actually might put off some other people, and that we had to be sensitive to everybody really about that. It's quite important that probably venues are both local and easy to access, but also there's nothing about them that is going to put people off going because of various, you know, concerns or beliefs about the sort of venue it is.
Yep, I think that's very true. Yep. Okay, well, I think everybody's fed back, and it's almost time to say thank you. I want to say thank you to everybody for coming. It's fantastic to see people and to have these kinds of conversations, even though it's across the screen, and I'm looking forward to meeting people in person. I think we're all sort of fairly desperate for that. I want to particularly say thank you to our great speakers, Ian and Nick, for starting us off on thinking about the issues that we currently have with this pandemic. Also like to thank our organisers, Alex in particular, for all her support and help, and Steve for all the backup as well. Thank you, Steve. So, and then I want to publicise our next webinar, which Jack, I don't know if Jack, you want to say a few words about it, but we're going to be doing one on long COVID in 2 weeks. So that will be
yes.
16th,
Can I? Sorry.
16th,
Can I?
Yeah.
I will just say something. So I think long COVID is certainly in the plan. I'm not absolutely sure yet whether it will be in 2 weeks. Okay. So just hold your horses. We will do it no later than a month, but it may be that there's a film documentary that's been made that people are suggesting that we might show in 2 weeks' time. So we're going to continue these every 2 weeks. Certainly for the moment, long COVID will appear, but it may not be next time.